talk about the thumb. Okay, so let's talk a little bit about the anatomy of the thumb. The interphalangeal joint is similar to the others. We have collateral ligaments on either side to stabilize the interphalangeal joint. The metacarpophalangeal joint's a little bit different in that you have the collateral ligaments, but outside the collateral ligaments, you have the abductor and adductor aponeuroses. And we'll see where this is important, especially on the ulnar side, where this can interfere if you have a tear of the ulnar collateral ligament here. If it gets flipped, it can adhere not back to the bone, but actually adheres to the adductor pollicis longus tendon or aponeurosis here, and then you can be left with an unstable first metacarpophalangeal joint. So you're all familiar with that, the Stener's lesion. So we'll talk about that. If we go on the axial plane, you've got the collateral ligaments anteriorly, and there's accessory collateral ligaments a little bit more posteriorly, and then we can see the aponeuroses on either side. And then we can talk about the flexor tendon. There you can have sesamoid bones on the volar aspect of the thumb with the intersesamoidal ligament, and then the flexor tendon is usually superficial. Okay, on the sagittal plane, you can have volar plates, both on the interphalangeal joint as well as the metacarpophalangeal joint. And dorsally, you have recesses here, which when you get a fusion, you can see fluid extending distal and proximal to the joint space itself. Here you can see the flexor tendon, and then here's the volar plate. And with dislocations of the thumb, you'll not infrequently tear the volar plate here. It can be torn off the proximal phalanx or torn in the mid portion or off the metacarpal bone. Again, showing the ligaments. This is at the level of the first metacarpophalangeal joint. The volar plate's in here, and then the tendon is superficial to the volar plate. And then if we look at MR examinations, we can see the same anatomy, the flexor tendon anteriorly, and then there's also a pulley system here involving the thumb. The A0 pulley is here helping keep the flexor tendon close to the distal portion of the proximal phalanx. The A2 pulley is at the level of the interphalangeal joint, and then you have AV and the A1 pulley more proximally here. And then just like we've seen, actually, have we talked about the pulley system yet? We haven't talked about the fingers yet, have we?
We have not.
We have not. Oh, sorry about that. As we'll see in the other flexor tendons, where we see the pulley injuries probably more commonly, you can see that the flexor tendon, this is the pulley system. It comes around the flexor tendon, and therefore it keeps the tendon close to the phalanges, and we'll see why that's important in terms of function of the flexor tendons when we talk about pulley tendon tears. Here we can see a gross specimen here, radial collateral ligament, ulnar collateral ligament. Here's the adductor pollicis, and here's the aponeurosis coming across here. So you can see why if you have a tear of the ulnar collateral ligament, it could flip down underneath this particular aponeurosis and adhere to that and end up with an unstable joint. And again, the ulnar side is much more commonly injured than the radial side because it's easy to catch your thumb and cause abduction of the thumb. Whereas if you try to have force on the radial side of the thumb, it forces it against the index finger, and therefore it's more stable, and you're less likely to do a tear of the radial collateral ligament. And then this is just an article in Radiographics showing different appearances that you can get for ulnar collateral ligament tears. These are partial tears, 1, 2, and 3. Then you can get a bony avulsion from the base of the proximal phalanx, or you can get a tear, distal retraction, and then the tendon itself can adhere to the aponeurosis, in which case sometimes you'll get a large fibrous response here and a little bit of a fibrous mass. This then tends to inhibit healing back to the bone, leaving you with an unstable joint space, which can go on to degenerative disease. This is the so-called Stener's lesion and is generally considered surgical. John, what about the avulsion fracture of the base of the proximal phalanx? Do you treat that conservatively usually or surgically?
No, you usually fix it.
Okay, great.
A tiny little screw, and that's about it.
Okay. And here we can see an avulsion injury of the ulnar collateral ligament from the base of the proximal phalanx. And here we can see an injury here coming from the metacarpal head. Again, here we can see the aponeurosis is external here, so this is not, this would be a non-Stener's lesion. These tears just of the collateral ligament without displacement are generally treated non-surgically. And there are variable reports as to how frequently these lesions are Stener's versus non-Stener's. And some MR reports, obviously, by the time patients get to MR scan, they're a pretty sub-selected group. Typically, it's around 30% of the MR tears will be Stener's lesion and about 70% not. So MR can be helpful in keeping a lot of people from having to have unnecessary surgery. And again, we can see abnormality here with an avulsion injury from the base of the proximal phalanx. Again, this is not really a gamekeeper's thumb because it's not really displaced here, and we don't see the aponeurosis going into the defect. You can also see this in the axial plane, where here we can see the flexor tendon, extensor tendon. This is the area of the abnormality clinically, right in through there, and we don't really see the fibrous band. Not the greatest images here. Here it's proximally retracted, and we can see fluid collection here. Here's the aponeurosis out here. Again, this is an adductor tear, but on these images, I wouldn't be able to call this whether it's a true gamekeeper's thumb. I mean, whether it's a Stener's lesion or not. It's a gamekeeper's thumb. So the term gamekeeper's thumb, these were common injuries back in the days when on your estate you would have someone who kept game for the dinner table and would raise geese and turkeys and other game, and they would, when they killed them, they would just grab them by the neck and wring the neck, and doing that over and over again produce adduction stress onto the base of the thumb, and eventually that would get partial tears and then complete tears of the ulnar collateral ligament. And consequently, since it happens so frequently in gamekeepers, it was called gamekeeper's thumb. Okay, Tayson, what do you think here? Old images again. Sorry about the quality of the images, but it shows the pathology.
Yeah, so it looks like the distal attachment of the ulnar collateral ligament is torn
Okay, so
and
we don't see
displaced
it
proximally, right?
and it's displaced proximally. Here's the abductor pollicis aponeurosis, and you can see here in this position, if there is any healing here, the ulnar collateral ligament is going to heal to the aponeurosis, and therefore, if less untreated, this is likely to end up with an unstable joint. So this would be considered a Stener's lesion, and would be surgical indication to move the collateral ligament back up to its anatomic location where it would heal to the base of the proximal phalanx. So this would be a Stener's lesion.
It's not good to have instability on the ulnar side of the thumb. A little better off on the radial side, but not the ulnar side. Campbell's uses a rheumatologist classification, and they have
Right, there's something with the mic.
It's something with
four types.
Sensitive to
So somehow it
Mm-hmm.
turns the mic on. John, can you hear us now?
Yeah,
We can hear you now. We didn't hear what you
Okay,
said. We had that problem again. Go ahead.
I wanted to say that Campbell's has 4 different classifications, and they use rheumatology definitions.
Okay.
A fellow named Neil Buff, I don't know if you've heard of him, but anyway, what the classification is from rheumatoid arthritis, the different deformities that you have. That's what Campbell's uses for different problems with the thumb. Basically explaining everything that you're going to explain, but they use just number 1, number 2, number 3, number 4.
Okay.
You're supposed to guess what they are.
All right.
I mean, it's in the book, but
Yeah, I'm not familiar with that
but
system.
if you just said number 1, number 2, number 3, and 4, obviously that wouldn't help you.
Okay, good. Thank you. Okay, Elior, what do you think of this case?
Right, so looking at the ulnar collateral ligaments, yeah, on the sagittal view, it looks completely torn at its distal attachment and mildly retracted proximally. Yep, edema in the bone.
Yeah. Over here.
Yeah, there it just looks very lax on the
Right.
coronal view.
So this is actually was a dislocated thumb, and here you can see the volar plate is torn and its attachment here to the proximal phalanx. And in the coronal plane here, we can see that there's really a stretching injury to the ulnar collateral ligament. Maybe it's intact, but it's obviously not normal. And the clinician elected to treat this like a Stener's lesion because he thought if it did heal, it was going to be elongated, and consequently, you're going to be left with an unstable joint. Okay, Robert.
All right, so we have a hockey player that was checked against the boards and having thumb pain. Looking at the ulnar aspect of the distal MCP, looks like there's some soft tissue thickening there and some edema. So don't see the collateral ligament very well, so I think there's a tear there and another Stener lesion.
Right. And this is, if we go to this image, you can see kind of a little line here that's very thin, going up approximately, does not really attach to the proper location on the base of the thumb. This is called the string sign, and this looks like the end of a yo-yo. So this is kind of a string yo-yo, and the string sign and the so-called yo-yo sign are also indications of a Stener's lesion. And John remembers these because John at one time was a very renowned yo-yo.
Was a yo-yo champ of
competitor.
Detroit.
That's right.
All right, so I think the ulnar collateral ligament is avulsed from the distal attachment. I think that wavy structure is probably the aponeurosis, right?
Right,
They had
right.
out there, so it looks like another Stener's lesion. We have some fibrosis.
Right. So this is again the string sign, which is the aponeurosis. You can see it goes beyond the bone here. And this is the yo-yo part, and this is the retracted ulnar collateral ligament. So again, this would heal, would end up with an unstable joint. So this is a Stener's lesion. Good.
It was probably named in the 50s.
Mm. And
That's when the yo-yos were very popular.
right. I even remember those days. And here we can see the tear of the volar plate and its proximal attachment in this patient. So that was also injured. You took the last one?
Yeah.
Yeah. Elior.
Yeah, ulnar collateral distal attachment looks like it's torn, maybe an avulsed fracture fragment there as well.
Yeah.
Volar plate, yeah, torn proximally.
Probably here a little bit of edema there.
Yeah,
Yeah.
avulsed. Okay.
And right. This is actually, you're absolutely right. This was actually a piece of cortical bone, which you can see right there. Okay. And this was a Gamekeeper's avulsion, but probably not an actual Stener's lesion. But John, you think that these bony avulsions should be surgically treated, correct?
I think I probably would.
Okay.
I don't know if you adducted the thumb and whether that would heal. It probably would, but it would. It's a very inconvenient way to put a thumb to try to put the little chip of bone in place,
Okay.
and it's so easy to fix.
Good.
You
Thank
can fix it with sutures. You don't need a little screw, which we didn't have in my day.
Okay. Good. Okay, Robert.
All right, so here looks like there's a tear of the proximal collateral ligament there.
Yeah, the collateral, and to be honest with you, just looking at this, I don't know which one it is. But
Yeah.
we see a lot of bone edema here, and then we don't, this is the collateral ligament, it doesn't clearly come down and properly attach to the metacarpal head. And there we can see that. So this was an ulnar collateral ligament tear. And here we can see a lot of soft tissue injuries here on the T1 weighted image. And yeah, this was from France. So and you can see that there's instability of the joint here. I don't know whether this was surgically treated or not.
Well, this is definitely a surgical case.
Thanks.
What are those very dark structures right there? Yeah.
Yeah, I think that's the collateral ligament and the retinaculum on the opposite side. So I assume this is the ulnar side, and this would be the radial side then. Okay.
All right. 38-year-old male with thumb pain after dog bite. So I think we have a avulsion of the UCL and subluxation of the metacarpophalangeal.
Yeah. So that's another avulsion fracture.
I knew a doctor's daughter that got bit in the leg by a dog and walked away with $6 million.
Okay, so here,
Could you tell me where she got bitten?
The lower leg.
Yeah, but I mean,
It caught one.
who did
caught
she get
one
the
of the-
$6 million from? I've got to go meet their dog.
Yeah, she got a neuroma, and then she went all kinds of treatments, and
Wow.
and once you get into the hands of the guys that do this on a daily basis, she got her 6 mil.
Wow, that'd be good for my retirement fund. Go ahead, Leo.
Yeah, distal attachment of the UCL looks
Yeah.
torn.
And so here, this is, okay, so you're talking about right in there.
Mm-hmm.
Yeah. This patient's actual pain was on the radial side.
Mm-hmm.
And I should show it here. The next cut showed the ulnar collateral ligament was attached normally. So, but this, I would agree with you. I would call that just looking at this image. But this patient had a little bit of thickening and some edema on the radial collateral ligament. This was in a Major League Baseball player, and this was thought to be a radial collateral ligament sprain. I think this is the only one that I've really diagnosed that was confirmed clinically. Oh, no. Take that back. Forget that last statement. Robert.
All right, this is a 40-year-old male with first metacarpal protuberance after trauma. It looks like there's a tear of that radial collateral ligament proximally.
Yeah. Yeah, these are much less common than the ulnar collateral ligament, but they do happen. And this is someone who just has an effusion post-trauma. Usually when you get an effusion post-trauma, you're going to see some sort of a fracture, but not always. Sometimes you can just have trauma that may tear something of the capsule that you can't see directly and get fluid within the joint space. So let's move on to the proximal interphalangeal joints. And here on the sagittal plane, we can see that extensor tendon attaching to the base of the middle phalanx. So we talked about on the extensor tendons here. And then in this case, again, we see a volar plate with its attachment here to the proximal phalanx. And then you've got collateral ligaments on either side. So this is what and then again, if you remember, we have the complex anatomy of the flexor tendons where we have superficialis and profunda, and the superficialis splits on either side, comes back and attaches to the proximal aspect of the middle phalanx. The profunda extends through the split between the two parts of the superficialis and it goes on to extend to attach to the distal phalanx. And then here you can see the collateral ligaments on both sides, which we can see on the MR examination. And injuries you can see is thickening and increased signal intensity and edema within the collateral ligaments when you have an injury. Here's a normal collateral ligament, a torn collateral ligament, a normal collateral ligament. Okay, let's see who's next. Jason, why don't you take it?
All right, so this is like either a long or ring finger PIP. Looks like the collateral ligament is torn.
Yeah, so there's some thickening and increased signal intensity. Not great images. These are low field images. This is more than normal, and I'd be concerned that there are strains of both collateral ligaments. Here, probably a subluxation event that tore them. On the axial images, we can see there's much more asymmetry, much more injury to this side. And we don't have all the images here, so I don't know whether that's radial or side.
Okay, so looking at that PIP joint, yeah, on the Where are we at the radial side? Yeah, the radial side of that PIP joint. Yeah, there's that little.
Ulnar side.
Uh,
This is the ulnar side. This is the radial side.
okay.
Yeah.
Here's the thumb.
Or-
Yeah.
So yeah, the radial side of the PIP. I just see that.
Right.
Yeah, that lucency in that bone.
Okay. And thickening of the soft tissues around it.
Uh,
Here's a radiant echo in stir images where you can see thickening within the collateral ligaments and kind of an erosion or maybe a little avulsion. I don't see the fragment here on the radial side, which we saw in the plain films. And these are low field images. Okay. Robert?
All right. Here, looking at the, what I think is the fourth digit along. Yeah, there's a lot of soft tissue edema adjacent to the collateral ligament, proximal to it. So I think there's a tear of the collateral ligament, and then, yeah, edema tracking proximally.
Right. Good. Okay. Jason.
All right.
Trauma and I think this is a fifth proximal interphalangeal joint pain.
Okay, well, it looks like the radial collateral ligament distal attachment is torn.
6/16/03. There's a tear there. Okay. And this is 10/29/04.
It looks like it's scarred down.
So that's the tear before. So this was 6/16. And then this is over a year later, and we can see that it's healed. So these non-Stener lesions can heal. This is the fifth. Good. Okay, the hyperextension injuries, they're like everything else in the world, there's a classification system. This particular one from Clavero and radiographics, a type 1 is a disruption of a bowler plate. If you have this involving distally, you'll end up with a swan neck deformity. Proximally, you get a pseudo-boutonniere deformity. Type 2 includes tear also of the collateral ligaments. And the type 3, you get a fracture dislocation, which is divided into if the fracture involves less than 40% of the surface or greater than 40% of the surface, in which case it's surgery. Though I think in this day and age, there's a tendency to be more aggressive in surgery with these interarticular lesions than there was back in 2002.
I think that they don't use the 40%. What they do is fix it or don't fix it.
Yeah. So what do they how do they determine whether they should fix it or not?
If you need the money or not.
You're not supposed to say that, John.
Well, I'm not supposed to say that. I'm sorry about that. No, if you look at and examine the patient, if the injury looks more than just a nice smooth surface, you put it back together and fix it.
Okay.
If it's if you can put the finger back to do a buddy taping, you do that.
Okay.
But today, like you said, the hand surgeon love to operate on the
Okay, good.
and the 40/40 thing doesn't go.
Okay. Great.
I mean, what's the difference if it's 30/70 or 40/40 or whatever?
Right.
It depends on whether it's displaced or not. That's the main thing.
Yeah.
If it's displaced, fix it.
Okay, good. Here are just some examples of type 1 where you can see some thickening here, an injury to the volar plate. Type 3 where you have a fracture, interarticular fracture. And then here with the dislocation, we can see a tear of the volar plate as well as a tear of the tendon insertion. Okay. So just to reiterate some of the anatomy here, if we look at the flexor tendons here, this is just kind of shows dissected tendons where you can see how the tendons separate here, allowing the profunda to go through the superficialis and end up attaching distally here. And these are just the separation in the superficialis to allow the profunda to go through. And then if you go to the sides, you can see the superficialis coming here and attaching to the bone approximately. In the midline, you'll see the profunda goes through that separation between the superficialis tendons and extends distally to insert on the distal phalanx. Okay, who's next? Jason, do you want to take this one?
Sure. So we have a marker, palmar aspect of the wrist. I'm not sure I see a whole lot on this.
One of the hard things to see is something that's not there.
Mm.
So the question is, what's not there that should be there?
So the profundus of the
Okay, so the superficialis here of the third isn't there, where we can see it on the second and the fourth. And if you go farther down, we can see that here's the profunda. Medially, we don't see the component of the superficialis. Laterally, we're starting to see a little bit of the superficialis. More distally, we can see that the superficialis is really disrupted here and abnormal, though the distal insertions you go back and they look pretty normal. So this was a superficialis tear. It's chronic, and that's why you don't see edema that you would see in an acute lesion.
I think in some books it's called sublimus.
Okay.
Just to let the fellows know that there are more than one way to call these.
Thank you.
Okay, so here, history, trigger finger release now with palpable mass, and A1 pulley release. Right, so this flexor superficialis looks lax and torn, I think, and retracted.
And here, actually, we can see the abnormal superficialis, abnormal morphology, and this was they went back in and did surgery, and this was a partial tear of the flexor digitorum superficialis, right? Robert.
All right, so here, looking at the flexor tendon, the FDP looks like it's intact. There's some fluid surrounding the tendons and synovial thickenings. Be concerned about tenosynovitis.
Okay. And then if we go to the coronal images, we can see that there's a lot of fluid and soft tissue thickening here involving, multiple tendons, probably all of the flexor tendons. In the axial images, we can see the fluid here. And then here we can see extensive fluid collection with synovial thickening. And then this is flexor tenosynovitis in this patient with rheumatoid arthritis.
All right.
I think rheumatoid arthritis can give you every kind of injury you want or don't want of the hand and fingers and thumb. So I think that's why.
So I think we have
Campbell's uses that vernacular.
Yeah, the classification systems from rheumatoid
classification, right?
Yep. Okay.
We have a tear of the
Yeah.
profundus.
Again, this is an old image. Sorry about it, but we can see that profunda is not contiguous through here. And if you look axially, you can see abnormality. The superficialis kind of looks like it's intact.
Mm-hmm.
And that was a tear of the flexor digitorum profunda.
Right, so marker at the level of the PIP joint. The I don't think
It's a little hard on the sagittal to see that. We can see a deep tendon here, a more superficial one there coming across. We don't really see the deep tendon. Maybe we're partial alignment and missing it at this point, but it looks like it kind of ends there. If we go to the axial images, what do you see?
right. We don't see that deep flexor
Yeah,
tendon.
we see it up there, but see it much better at the other fingers. And then here, this is probably the kind of the volar plate, but we don't really see the profunda in the center here. We can see the superficialis on both sides, but there's no profunda sitting there. So this was a hyperextension injury and it was a full thickness tear of the profunda. Okay. Aha, finally.
Fixing these is a tricky business in many different ways, and you sometimes have to use silicone rods and keep them in for a period of time until the tissue heals up, and then you can put in grafts and so on. So it's strictly a hands specialist area of expertise. Ordinary guys like me nowadays don't do this stuff.
Thanks, John. Right. And then as we talked about, we have these fibrous bands that hold the flexor tendon close to the bone here. If not, the tendon will bowstring when you flex the fingers and extend out, not stay close to the bone, and therefore it will pull in the wrong directions, and we'll see in a little bit the kind of deformities you get when these are torn and the flexor tendons actually pull from abnormal directions. So we can see the A5 all the way through here. Typical one, the most common one that we see really is the A2 pulley injury in this location. As far as axial images on MR, we can see the pulleys as these fibrous bands that come around the flexor tendon holding it in case. The C's are the cruciates. When you get to joints, it's more of a cross rather than just a straight band going across it. But again, primarily the most common one we see is the A2 tear, which separates the flexor tendon from the proximal phalanx. So here's from Clavero's article again. We see a little bit of separation. This amount is kind of borderline normal. So I would be suspicious, but I'd want to really kind of compare it. In this particular case, and if you look at the axial images, you see the pulley really is intact. And then, but here we can see a clear-cut abnormal separation between the flexor tendon. And if you look here, there's subtly a little anterior subluxation of the base of the middle phalanx from the distal proximal phalanx, and that's the kind of instability you start getting when you have an A2 pulley tear. Now, when this occurs, what happens is now is that the profunda is going to basically pull in a straight line between here and back here, not across here. And so that's going to pull the distal, the DIP kind of proximally here. And the superficialis will still usually kind of be a little bit separated but intact, and we'll pull here. What this tends to do then is you get a flexion of the proximal interphalangeal joint. You get a extension of the distal, And this is, you end up with a boutonniere type deformity. And again, this was common in the rheumatoid days.
The pulleys are the biggest problem for doing surgery on the hand. Wherever the pulleys are, there are a lot of them. That's a problem for the tendon because they like to adhere to the pulley. So either they attach to the pulley or they're too loose, and so it's a headache one way or the other.
And these pulley injuries are common in rock climbers and people who have to grip a lot with their fingers. As you can see in this position, if you put a lot of force,
Yeah, that's the no man's land area. That's the one area where you don't want to have a problem with the tendon.
Yeah.
Where those two pulleys are.
Yeah. And so here, this just shows examples of tears with fluid around the tendons on an ultrasound. And on the MR examination, separation, increased separation here. Again, that subtle instability of the proximal phalanx, and you can see the extension of the distal phalanx here on the MR examination. Again, the separation here. This is a slightly different location on the other fingers, but that's abnormal separation with too much fluid in here, typical of a A2 pulley tear. And they go in, and this just shows opening up, seeing the flexor tendon, the pulley's not intact. And yeah, so A2 pulley tears. Is Robert next?
Yeah, I think so.
Okay, go for it.
So this is a 32-year-old with pain after injury. And it looks like there's a flexion deformity at that PIP joint and an extension deformity at the DIP.
Right.
You
can see the abnormal separation here.
Yep.
In this case, there's probably a little bit of an injury to the distal articulating surface of the proximal phalanx. And notice the instability of the proximal interphalangeal joint. As I was talking about, this is a little bit more prominent. And you can clearly see how the superficialis comes around here. The profunda is way out here pulling in the abnormal direction. And you end up with a typical boutonniere deformity.
And joint is subluxed.
Yeah, joint is subluxed. And this just, again, these are slightly different locations because the fingers are different lengths, but here you can clearly see the separation from the pulley tear as opposed to the normal pulleys with normal positioning. So that's an A2 pulley tear.
All right, 12-year-old tennis player, acute pain with flexion. So it looks like middle finger at the ulnar side of the pulley. Looks like it's torn.
It's thickened with a lot of increased elasticity, though we don't see a displacement of the tendon at this point. That's what it looks like when you kind of blow it up. Normal side over here, abnormal side over there. And then here we can see maybe a little bit of edema back here, but this was a partial tear, not a complete tear. So you don't have complete separation here, but this is a high-grade partial tear, putting the patient at risk for further injury.
Right, so here, edema around that flexor tendon, the long finger. There's some separation, some bowstringing, and yeah, it looks like tear of the pulley and fragments displaced between the tendon and the bone.
And then here's that displaced fragment in between of the pulley.
If you have a pulmonaris longus, that's what you use to replace the pulleys most of the time.
Okay. And then
not everybody has it. I think like 80% have it.
Okay. And then here we can see another A2 pulley tear with separation there. And here again, we can see the A2 pulley tear, the bone injury associated with it, subluxation of the proximal phalangeal joint, and the development of the boutonniere deformity. Okay, Robert.
All right, so we have a rock climber MR 1 week after injury during crimp hold, ultrasound 4 weeks after the injury, or I guess MR. Here, looking at the A2 pulley, that looks like it's intact. There's a little bit of separation, kind of at the middle phalanx. There between the flexor tendon and the phalanx.
Yeah, there's a pulley right there, or should be.
Yeah.
And then the axials are very helpful here because with the axials, you can look at the separation of the tendon at the level of concern on the digit you're concerned about. Then you go to that same level on other digits, which actually is going to be on a different slice, and you can see whether there's abnormal separation. So you can kind of compare that. The other fingers be a guide. And this is the ultrasound. A little bit later, we can see some separation here that's abnormal. And this was an A4 pulley tear, more distally. And then here's another A4 pulley tear out here. Okay.
All right. So the DIP is held in some flexion here.
Okay. So
Yeah, there's some separation of, I guess that's also A4.
okay. And then is what I kind of want to show here is notice that this joint is deformed. It's
Yeah.
no longer normal. That takes time for that to develop. And this is what you can see in a chronic pulley tear. You end up getting bony deformities, which are fixed.
Okay.
The only thing you can do with that probably is to fuse it, fuse it, because you won't get it to move properly if you don't. Um, in other words, you want function rather than pain. Very common condition, trigger thumb.
Yeah, I think we lost you guys.
You're back. I'm back. I don't hear Dr. Crues.
Yeah, I don't either.
Maybe I should call him.
Looks like he's adjusting. Yeah.
Cannot hear you, John.
Yeah, I can't hear you either.
Call.
Can you hear us now?
Yeah, we can hear you.
Yeah, we can hear you now.
Okay.
I just turned off my phone. I was just ringing it.
Okay. So trigger finger. So but basically that's where you try to flex a finger and it gets stuck. And often you can kind of force it beyond that, and then it will flex freely. And there's a lot of debate as to what causes trigger fingers, but generally it's thought that it's due to some swelling or increase in the cross-sectional diameter of the tendon with respect to a pulley. And therefore the tendon will catch on the pulley and keep it from moving smoothly. Certainly with the trigger fingers I had, whenever I would kind of move it past that point, then it would be free and not have a problem. Most of the time, I've generally found that for trigger fingers, MR is pretty negative. But what you kind of look for is evidence of edema and tenosynovitis in the area of the symptoms. And sometimes you can just have tendinosis with thickening of the tendon with increased signal intensity due to tendinosis. But I find that most of the time MR is not very helpful. Here we can see,
Clinically, it's easy to diagnose.
yeah, and here we can see kind of a small tendon there. Here it's thicker with increased signal intensity within it, so this is tendinosis. And then here we can see still tendinotic tendon, and that thickening probably gets caught up in the pulley system and causes the trigger. And right there is the marker showing where the triggering is occurring.
Got an hourglass appearance.
Okay. All right. See who's next. I don't know.
A lot of them can be treated with cortisone, and they
Actually,
and rest go away.
actually, why don't we stop here, and we'll finish the rest of this lecture tomorrow, and we'll start the inflammatory lecture after that. Okay. Great.
You're gonna start what?
We'll finish the lecture on the tendons tomorrow, and then right after we finish that'll take us about another 10 or 15 minutes, and then we'll start the inflammatory disease.
Okay. We'll see you guys tomorrow. Have a good evening.
Great.
You too.
Thank you. Good to see you.
Drive carefully.
Thanks.